Okay, I think we'll make a start. Welcome everybody. Hello, thanks for joining us. Today's webinar, which is part of a series of webinars delivered by HCV Action this week. A breakout, if you like, from one of the main sessions delivered on Tuesday to which was a larger ODN meeting and co-hosted with Basel. And I think if you did miss Tuesday's meeting, there's the opportunity to go onto the HCV Action website and catch up. I'd also like to thank especially Tracey, Kemp, Helen Hampton and Julian Surey for coming along to talk today. And also Archie Christian, who's going to help facilitate some of the breakout sessions that we've got planned in a minute. So the format, before I pass on to the first speaker, in typical Zoom fashion, it will be the usual power imbalance of people speaking at you and you as entrapped listeners listening, but we are trying to make it as interactive as possible. And so at 2:45, we're going to have some breakout rooms and you will all have an opportunity to participate in discussion. There'll be, I think, 4 breakout rooms, each with a host, and it should be relatively simple for you to follow. I think on your screen, it will just pop up as a message for you to click and join your assigned breakout room. They will last for approximately 30 minutes of discussion, and then another sign will come up on your Zoom telling you to rejoin, and we'll spend the last 15 minutes hearing from each individual group and summarising the discussions. We have the ability to be asked questions as we go along. So when the speakers are delivering their presentations, please use the chat, which is at the bottom of your screen. You can type questions in, and once the 3 speakers have finished and before the breakout sessions, we will go through and ask some of those questions and possibly direct them at individual panelists if appropriate. So I think that's it from me. The introduction's done. So I'm going to pass you first of all to Helen Hampton, and I will leave Helen to introduce herself and deliver a presentation.
Thank you, Stuart, and welcome everybody. My name's Helen Hampton. I am the Blood Borne Virus lead for We Are With You. And I also have the wonderful job of treating hepatitis C in the community in Cornwall, one of our services. I've been invited today to talk to you just to give you an overview of testing pre-COVID, during COVID and after COVID, whatever that looks like. So I should just talk about pre-COVID first, where everything was all wonderful and people were coming into service. We delivered face-to-face training, virtual training and e-learning for all of our staff so that they had the ability to have a conversation with our service users, and they had the ability to provide dry blood spot testing for anybody that wanted that test. We offer testing to everybody that comes through our service, regardless of risk. Many of our services follow the opt-out approach. And prior to COVID, we were making this mandatory for all of our services as well. We, like I said, we test wherever we can. So we test assessment, we test opportunistically, we test through our needle exchange, and we work really closely with Hepatitis C Trust and with our peers, and test in all sorts of venues and places. So pre-COVID, we were doing really well and we had increased our testing, and testing was firmly on the agenda where people were found to be Hep C positive and placed on the referral pathway as quick as possible. However, then of course we had COVID and we had the lockdown, and we had to dramatically change our practice. We had to move to offering more of a remote service where support was mainly given to our service users through a virtual platform, whether it was on the telephone, whether it was through WhatsApp. and we were only able to see a small number of service users in service, and that was based on the need, the vulnerability and the high risk. We still maintained delivering our harm reduction advice, and we did that through social media, the website, through our local networks, and we picked up and offered a click and collect needle exchange service. Regarding testing, we tested people, the high risk service users that came into service, and in some of our services we were able to work with other services and test our homeless population, which was opportunistic, and maybe that was a positive part of COVID. And I don't think there are many other positives of COVID, but I do believe that that was one of them. Our testing numbers have reduced, and some of our services have ceased. As we are coming out, well, I don't believe that we are coming out of COVID as yet. We don't have the national lockdown, but we do have restrictions in local areas. We are concerned that there's a fear and a lack of confidence amongst our staff on returning to testing, and of our service users coming in to be tested. So we're looking at how we can do that, and we have utilised some of the postal testing, and we are seeing service users when they come in, the high risk service users we're not seeing for a long time, then we are testing them, but obviously that has reduced. As we come out, we hope that through our risk assessments that we will be able to see more of our service users, and we will be able to do more of that testing. I'm going to pass on now to the next speaker.
Okay, thank you very much, Helen, from We Are With You. I'm going to just remind people as we hear from the panelists, please type questions, testing related, and into the chat box, because once we've finished hearing from the speakers, we will be having a discussion relating to the questions offered. So next up, with great pleasure, Julian Surey, and I will leave him to introduce himself and tell you about what he's been doing recently.
Thank you very much, Stuart. And is my audio working? We have to do this obligatory introduction whilst we get through the technological issues. Good. I'll share my screen. This is the next hurdle. And I've got a few slides. I'll rattle through them quite quickly, I think. I hope to, anyway. Is that working? So I work for, so a lot of these are a bit of a disclaimer before I start. I work for the Find and Treat team, and I've unashamedly stolen a lot of these pictures, these slides from Al Storley, who's the lead of the service. And I'm going for a pint with him later on, so I'll make it up to him. Essentially, so I work for the Find and Treat team. I also work for UCL, which is the, I do research there in inclusion health and infectious diseases. And the Find and Treat team has been going, it's going for 10, 15 years now, or so now. It's a mobile outreach service. We go around with a van, essentially, in the services around the van. It started off about 10, 15 years ago, like I said. It's pan-London, and we target homeless populations. And we do about, originally the service started with a chest x-rays looking for active TB amongst this client group. We do about 8,000 a year. We go over 360 venues, and we do 20. It's a constant bit of furniture across London. So we go out into the community. We access any homeless venue, congregate setting. Anyone is welcome. Very low threshold of people coming in. Any excuse to put a picture of animal on there always gets someone's attention. like I say, a low threshold. You don't need to be registered with a GP. You don't even have to give your real name or date of birth. It doesn't matter. Joe Bloggs, first of the first 1960 is fine by us. And with the chest X-ray, where it's like that's the central part of our service, has been the central part of our service. It's non-invasive. It takes about a minute. You go on the van, zapped, and it's reported straight away. So your results you get straight away, and explained to you there and then. We have a very strong peer component. So we've got a high proportion, probably about 50% of our staff have experienced homelessness or have been on the receiving end of the sort of services we provide. And as we know the backdrop of homelessness in the UK. This is data from, well, there's different ways of measuring homelessness, but essentially it's more than doubled over the past 10 years or so. So unfortunately, it's very good for business at the moment. So our service, like I say, it started out being the TB van. And over time, we've latched on different interventions. So if you think of TB, that's pulmonary TB, the tip of the iceberg. You've got latent TB, so TB infection below that can be up to 1 in 6 of our client group. With Hep C, we did a previous bleed about, it was published a couple of years ago. We're looking at about 1 in 10 infected with hepatitis, chronic Hep C, and about 1 in 100 with HIV. That just goes, and it's basically, it's driven by the collinearity between BBV and TB infection amongst homeless. A lot of it is driven by drug use, opiate and cocaine use. So it's not just, so our main sort of work is with infectious diseases, but with non-communicable diseases. This little slide looks a bit busy, but don't worry about it. Basically, you're looking at these asthma, COPD, epilepsy, heart problems. The blue lines you can see there, this is the housed population split up with how deprived it is. So the darkest blue is the poorest housed population. And in the red, you see the homeless population. You can see that the prevalence of, for example, asthma, COPD, epilepsy, and heart problems is far higher than the poorest housed population. So it's a massive health inequality. We similarly did some work with some cardiovascular screening, looking at hypertension, diabetes. This is actually measured things rather than self-reporting impaired glucose, and a similar picture. High rates of hypertension, hypercholesterolemia, so high cholesterol, and diabetes. And a lot of this is untreated. So we've tried, again, we started off with this big van based on chest X-rays. We try to latch on, well, we have latched on many different services over time. So we've got, so you can go into have a chest X-ray. If you're symptomatic, you can have a sputum for on a gene expert for TB. You can have a mouth swab for Hep C. You can have a fibre scan, and on the way you can have a flu vaccine. And we're always looking to add on extra services on the back of that. So we're all tickety-boo hanging on with that. And as we know, the reason we're talking today is COVID came along and basically essentially put a span in the works. And we just dropped our regular testing. Chest X-rays are not a very good diagnostic for COVID anyway. We just did we completely stopped our regular testing network and dived into COVID. And looking back, I did a presentation with my group a week or so ago, and it was only when I looked back at it to realize that, and I'm sure it's been for everyone else that is on this call, it's been a mental year. And if you think about lockdown only happened at the end of March, and then by beginning of April, we're out doing testing in London. And I'm sure, again, this is mirrored in everyone else's experience. London was a very strange place, completely empty, apart from there was a large homeless population. So fair enough, the government did step up and get some money in. And we did, as we know, all these homeless hotels were opened up across the country, but particularly in London. So the GLA opened up spaces for about 1,200, 1,300 people. And the different local authorities opened up different hotels, depending on the area. It all got a bit messy about where they were, but essentially there's probably up to about 5,000 people in this temporary accommodation. And the majority would have their own en-suite facilities, food, and essentially they're taken out of harm's way and sent on the street. Having said that, there was a significant group of people still out on the street. It's probably best that particular group stayed there. So we set up a triage, assess, cohort and care strategy for homeless individuals, working on the fact that they are to protect the most vulnerable. So a lot of these people have a large number of comorbidities, as I mentioned previously. We want to reduce transmission risk, prevent outbreaks, minimize impact on NHS, and prevent high mortality. So it had 3 main prongs, basically. So we opened up what's called a COVID care facility. And this was for people with suspected or lab confirmed cases of COVID. That was out in City Airport. We had something called COVID Protect, which was these new hotels that were opened up. Like I said, they had their ensuite facilities, food taken in, and lots of different services. And hats off to organisations like Mungo's, Turning Point, Look Ahead, that did a huge amount of work, CGL, that did a huge amount of work to get methamphetamine prescribing, mental health assessments. It was crazy times, and hats off to those people. And then the third lot was basically a lot of people that were none of the above, but they remained in the community, but they had regular symptom screens, and a lot of those remained in the regular hospital estate. I won't go into that too much detail, but basically we phoned around. There was a surveillance system phoning around saying, does your facility, or do you know anyone that's symptomatic? And then we, as I mentioned, we went out, we retrained all of our staff to go out and do COVID testing. And we did loads, and we found quite a lot of cases at the beginning, and it quickly tailed off. So I showed that was this is very busy, don't worry about the detail of the stuff, but basically I think the last one, we've picked up some positives recently, but for quite a long time, the last one positive was late April. So we looked at about having the first wave, we were a prevalence about 3-4% of people infected. And when you compare that with the US, hold on a second. Yeah, we're looking at 30 or 40% of people infected. So I think there's a real success from that point of view. This is a little bit where this shows the MSF stuff. I think it's the first time that MSF have been deployed in the UK. They ran this COVID care hotel near City Airport. Yeah, basically in the States, they just said put people head to head, and hence that's a situation we have in the States. So whilst we, again, the end of the initial wave in homelessness, I think was pretty good. What happens longer term is a separate issue. So get to BBV. So what we did, we had a pretty rough and ready COVID testing thing around London, kept testing people for COVID. And then we very quickly thought, not just us, but a lot of organisations thought, what other services can we supply to these people? So we spoke to an organisation called the Fast Track Cities Initiative. They were, yes, great. They gave us 1,500 point of care HIV tests. We spoke to the NHS England HIV programme and the other ends. They gave us a load of Hep C tests, fantastic. We stole some money from Andrew Haywood's discretionary account, and so we could do Hep B testing. This is a bit cheeky, but basically we wanted to do latent TB testing, but it got bogged down in bureaucracy and wanting to arrange meetings. But anyway, so the collaborative effort was amazing. So from Find and Treat, the Hep C Trust, Fast Track Cities Initiative, Groundswell, everyone, it's all hands to the pump. And we essentially did, it was point of care testing for, this is quite in the middle of we're not socially distancing in this picture, as you can see, so forgive us. And I look like I'm on a centerfold in the middle of it. But I just thought this is really important, because I think that the people that we sent out doing all these tests were, like half of them, the Hep C Trust crew, any waste of strays, there's a medical student there as well. And essentially we just trained everyone. And if I can do it, anyone can do it. So we're doing point of care Hep C, antibodies, Hep B surface antigen, HIV and a syphilis test. And all these people got the results straight away. And on the top of that, anyone symptomatic got a COVID test as well. This just shows how glamorous it was. This is with Craig Brick and John from Find and Treat in Southall. And we've got a whole gallery of where we ended up testing these different places, basically just to be flexible. You've just got to think outside the box. It's not going to be perfect, but you just have to do it. Otherwise, you just get bogged down in nothing will get done. So I'm blathering on quite quickly, but I'm cautious of time. The results, we're up to, I was just looking, I've got to do another presentation tomorrow, and I think we're up to about 1,200 people that we tested since May, but this is a rough kind of cutoff to the mid to late June. So over 800 people tested. The makeup was mainly male, which mirrors usually the homeless population that we have. The mean duration of homelessness is about 3.5 years. I think that's quite old. And I think anecdotally, there was a lot of people that are newly homeless in this cohort, speaking to people that have been just flushed out of the insecure housing as due to COVID. Plethora of countries of birth and many from that will have, potentially, that's the problem we'll have, will be no recourse to public funds. High amount, well, not a huge amount. So I think the risk for BBVs was lower than I expected. Our normal work is in the regular hostel estate, but still a significant amount of people inject drugs and smoking crack and heroin, and that had implications obviously with the services provided to keep people on methadone maintenance. But essentially, we found about 68 people antibody positive. It's about 7.5% of the population. That's to June. And then 38 of those, so just over 4% of the population were RNA positive. Many of these were eligible for same-day treatment. We've got a little scheme that we do in North Central London with the guys from the Royal Free and Morton Market. We have a virtual WhatsApp approvals process. So if someone is, they've got confirmed RNA infection, they've had an eye fiber scan, and they're not got any weird and wonderful medication they take regularly, then we have a virtual WhatsApp between a couple of consultants and a pharmacist at the Royal Free, and they will dispense tablets, pangenotypics the same day. So many of those are eligible for that. They all get peer support, and there's a lot of people in the Hep C Trust on this call, but that has just been the biggest take-home thing to me. It flushed out a real can-do attitude, and it really got some of these key players and a fantastic network across London, the Hep C Trust for peer support. So they're the two things that I'll take away. This just scans out our same-day treatment thing. So basically, they're positive. They get fiber scans confirmed. We just dish out the meds, and I think that I'm sure there's other people doing that across the UK. So this compares with some of our previous work. Something we wrote up. This was in collaboration with Hep C Trust and Groundswell as well. That's not a prevalent study, but we were getting like targeted testing. We were getting up to about over 42% chronic Hep C infection. I think that's maybe discussion. It has been useful with offering tests for everyone, but it does get a bit mind-numbing of and I think universality of testing is important. And I think that's where we are in elimination. We have to test more. It does get a little bit difficult testing a lot of people with low risk factors. But we did a cost effectiveness analysis of this from the people at the University of Bristol, and our previous work's been found to be cost saving. So that's all good. And second thing, or is it a third? I can't remember. So one of the other good take homes that we got from this intervention is flushing out collaborations. Particularly, we want to do HIV testing in homeless populations for years now, and the Fast Track Cities Initiative made this possible. And we found quite a lot of people. We didn't get any new diagnoses of HIV, but we got many were either on treatment or known diagnoses, but were just lost. They weren't linked into care. So I think it's some really important work we can do there. And we also had a little nibble sexually transmitted infections, because the HIV test we got is a joint syphilis one, and that is some future work we want to do. Is we want to do we want to do an application to do some more mobile STI testing this group. So wrapping up, so opportunities, as I mentioned, these collaborations are fantastic. We've just applied for an NIHR bid to do some video observed therapy after we're doing successfully in TB patients. So fingers crossed we get that. If not, we can try for other sources of funding. I mentioned sexual health and the other collaborations. But finally, as now we're going back into, it's not a second wave. It's never really gone away. It's just coming up back again. We're going into winter. Are we going to open up some of these congregate homeless settings? Is the will there to carry on with temporary accommodation? We don't know, but we need to be very cautious and mindful about the increasing infection as we go through the winter. As we know, it is, it's infectious, and we're going to have some clear strategies how we deal with this going forward. That's your lot.
Thank you, Julian. Thank you very much. It's a great model of whole care, and obviously very well placed to go and do what you did during COVID. Fantastic work. And I love the innovative approach to approving patients for treatment via the MDT on whatever format you use to communicate that. So I'm going to move swiftly on to our final speaker, and then we will have the question and answers as you've submitted them through the chat. So please keep them coming. I'd love to introduce now Tracey Kemp from CGL, and I will let her introduce her role.
Thank you, Stuart. So as Stuart has just introduced, my name is Tracey Kemp, and I'm the National Hepatitis C Strategy Lead working at Change, Grow, Live. So I've been invited along today to talk to you a little bit about the self-test option that we rolled out across all services in Change, Grow, Live in August of this year. So as most of you are aware, in March of this year, kind of the country was thrown into chaos when we had to pause testing across services to kind of manage the COVID-19 pandemic. That pause in testing brought about a bit of an opportunity to review and redesign the testing offer that we had in place, which was kind of your old, what we probably refer to now as your old school dry blood spot test. And what we've done throughout that process and that time of pause, if you like, is to develop a BBV toolkit. And within that toolkit was the self-test option. Throughout this webinar, I will refer to the toolkit quite a bit. So what I'm going to do is at the end, I will post a link to the toolkit that is now available on the CGL website for you guys to kind of have a look, see what resources are in there and if they're of any use to you. So one of the first things that I want to point out is kind of the importance of the collaboration, I suppose, in the development of the self-test option, and how closely we worked with peers within the organisation and the National Service User Council. So much so that when we first took the self-test option as something to kind of discuss, we were referring to it as a postal test. And it was actually the National Service User Council that very quickly identified that actually it would be best placed if we call this a self-test as opposed to a postal test. Because they felt it put a little bit more ownership on the individual to complete the test, which we really liked, and hence the term the self-test was born. So we trialled the self-test as a process, if you like, with members of the Service User Council. So we initially had 23 people came forward and kind of identified that they would stress test the concept. So that was from the dry blood spot test being sent out to their home, follow through of the process kind of from start to finish. It was really successful from the point of the 23, we had 21 tests that were posted out and we received 19 results back by the lab, all of which were able to be tested. So what I mean by that is there were no indeterminate test results. Now for us, this was key because I'm sure for those of you who do carry out dry blood spot tests, you're aware that at times some tests do come back as an indeterminate result. This can often be due to drying time and kind of, people are busy, so they think, that sample's dry and off it goes in the post and it arrives at the lab and actually the sample isn't sufficient to be tested, hence the indeterminate test results. So we looked at why was it that kind of a group of people who don't ordinarily test were able to complete the process from completing the test at home, post a sample to the lab that was then able to be tested. And some of the conversation was around how the self-test almost creates space and calm in your own environment to be able to focus and kind of complete the test versus busy services, workers who are kind of spinning lots of plates, lots of different priorities. So I felt it was just really important to kind of share that with you today, as I do think it's a conversation piece and it's something that we need to speak more about with our workforce in relation to kind of testing in general. So in terms of the self-test, I want to kind of share some points for consideration, if you like. The first one being we must be patient. So uptake with the self-test can be slow. So people are anxious. Naturally, the world that we're in, we've got anxious people in terms of staff and people who use our services. So the self-test option as a new approach is a new approach, and with that it's kind of important to create that space for people to become comfortable with the concept without them feeling like it's just something that you put in the post, you send it off and that's it. Actually there's a lot to consider and a lot of support that needs to be in place for that process to be successful. We need to also bear in mind that regions across the country have different restrictions in place due to COVID, which makes it difficult for services to plan for the future, which I suppose why it's even more important that our services do feel supported and that we have the appropriate guidance to support the delivery of kind of self-test or testing in the safest possible way. So I will refer back to BBV Toolkit on the CGL website, has got kind of all that staff and service user guidance that we've developed around the self-test option. In terms of self-testing, it does have its place. Bear with me. It does have its place, but it's important that it doesn't become a one-size-fits-all. Workers need to appropriately assess the likelihood of someone kind of engaging in and carrying out that test. The last thing that we want is lots of tests being sent out in the post, bit of a shotgun approach where we just get all the tests out. It's not about that. It's about who's appropriate for this testing option. And kind of one of the focuses now within our organisation is working with services to kind of ensure that what I would refer to as the back end of the self-test process or pathway is really tight, and that people have the right support when conducting the test at home. So things like check-ins, talking people through the testing process via phone, ensuring that they understand the guidance appears to be some of the things that are coming through as an appropriate way and a way that's helping people to complete the test at home. Whilst we have the self-test option, it is important also that we've kind of worked with our staff to break down barriers, and as Helen mentioned earlier, staff are anxious. It's important that we increase confidence around dry blood spot test as we once knew it on site, where appropriate of course. So things like talking through what PPE is available, what risk assessment tools you have in place, that kind of guides decision making, just supports kind of the wider testing piece as opposed to just being focused on testing in service or self-test. It's about what options do we have that are going to support us in getting testing back up off the ground. Something else that I often have to remind myself of is that we're still very much in the midst of a global pandemic. So services are working hard to deliver outside of what we refer to as critical functions, and testing is one of those areas. So it's about being patient and I suppose supporting our services. We are optimistic for the future, and it is important to recognise the struggles that we are likely and we are facing when we kind of look to return to a normal state of delivery. However, working together, coming together in such as webinars like this and external forums that we all link into, we're in a much stronger position to kind of make up for lost time, if you like. So to finish off, what I'm just going to do is run through some of the tools that are available within the BVV toolkit. Kind of the toolkit initially was developed as a tool to support services operating across CGL to relaunch testing. However, we very quickly realised that, of course, we're much stronger in our quest of looking to achieve elimination if we share what we have. So it's out there. If when you look at it, you've got any questions or queries, need any support in terms of if you're looking to implement any of the tools, please come back to me. I'm more than happy to help. So some of the resources that you will find within the toolkit are an implementation tool, so a bit of a step-by-step guide around how we've introduced testing within services. And when I say testing, that covers dry bloods, self-testing, opportunistic testing, opportunities where we can drop tests off at other locations. So it's kind of all in there, a bit of a menu of options. There's a frequently asked questions, there's a priority matrix, self-testing guide, which kind of helps staff members identify the most appropriate testing option for somebody and kind of the steps you would then take to carry out once you've identified the appropriate option. There's a nod to the need for risk assessment and how that supports us in appropriately managing risks associated, whether that be with self-test or testing in service, for example. There's some service user information in terms of step-by-step guides, visual tools, and your old school kind of leaflets and letters. And then there's a whole host of supporting guidance for our staff, because ultimately they're the people who are going to drive this forward. And I just think in terms of the self-test, so we launched on the 6th of August, and we were raring to go and very excited by what was possibly and potentially to come. And the reality was that the figures and the data that came out of the self-test were much lower than testing in service. So when we relaunched testing, we assumed that the workforce would just go for the self-test option and get the tests out, and that wasn't actually the case. What we found was that in the month of August, we had more people engage in testing on site, as we call it, versus the self-test option, But then what we've seen throughout the month of September was kind of a gradual increase in the self-testing option, which kind of brought the two on par. So definitely heading in the right direction, but the key is just making sure that, you know, if you choose self-test as an option, as I've mentioned earlier, that it's the appropriate option for the person sat in front of you, and don't just kind of do it to tick a box. Is this really going to help somebody? Can they support themselves through the completion of the self-test? And you know, what can we do to ensure that we're supporting the individual? So yeah, I think that's everything from me. I will post the link in the chat and come back to me if you've got any questions.
Thank you very much, Tracy. It's a hot topic, I think, postal testing, self-testing. It's really, I think it's great that you've shared your learning through developing the self-testing intervention on your website. And I presume that anyone can access that and use it as they wish.
Absolutely. If you know, if a service, if someone decided to literally uplift what we've got and rebrand it, that's absolutely fine. It's there for us. People need it.
Okay, thank you. So thank you all. And the chat has come alive, so I'm going to work sequentially through some of the questions that have been asked. First one, obviously, because Helen delivered the first talk. Someone's asked, Ewan Stewart has asked Helen actually about postal testing. I'm not sure, Helen, did you have you rolled out postal testing within We Are With You services yet?
We in Cornwall, because of the treatment service, we've done postal testing. So as soon as somebody's completed their treatment, instead of bringing them into service, we sent them a test there, and that's where we started our postal. And we have started to roll out the postal testing to our other services as well.
Okay, so it's used for SVRs and such.
That's what we used it for first, was the SVRs.
Okay, all right. I mean, that question was from you, and I think Tracy went a long way to answer a lot of that. And there's also the toolkit that should explain in more detail. So Petra in Scotland, hi Petra, has asked, again to you, Helen, I guess, you mentioned the staff's fear of resuming normal services or specifically testing, and what steps can be done to reassure them in light of, I suppose, do you envisage it's a fear of COVID specifically? I presume it is. And have you done anything with staff to try and just get them out and doing it again?
I think it is a fear. I think it's a fear of COVID, and I think it's also the fear of when our service users come in, that they're coming in for what they class as priority. And it's the fear of not wanting to keep them in the service for too long. Yes, we have done risk assessments, and we've got our full PPE like all of the other services, and we are reassuring our staff and our service users that they can come in for a test. We have our risk assessments on a rota system, so that when we do have our clinics, that we don't have too many people in the building at any one time, and we try to, wherever we can, use a one-way system as well. So yeah, the reassurance is there. I think it's because we had the huge lockdown and everybody had to change their practice really quickly, and now it's about sort of getting back to some sort of normality, because COVID's is going to be part of our lives for a lot longer, and we have to work with it.
Okay, thank you, Helen.
Thank you.
So moving to the next question from Mark was, I think, directed towards Julian, who mentioned, I didn't think you could get any more services on that van personally, Julian, but when organising commissioning for funding of additional services, how does that work? And I guess, is it a case of commissioners are generally happy just to bolt on to the existing service, or?
Oh, commissioning. How does commissioning work? Full stop. So I think I put in the chat, a lot of our early work, as you know, Stuart, it was done by bits and bobs with research money, basically. And that was EU money that finished approximately a year ago. So we got some good evidence with this cost effectiveness stuff that I mentioned with Vickerman's crowd in Bristol. So I think we had a strong evidence base, and then finally we got commissioned by NHS England, because there's not many, all the ODNs, especially London, is all chopped up. We're the only ones that work across London. So the evidence and the numbers really helped. To get the other stuff, the problem is, so we work hard, our main drive is homelessness, and we do want to do everything. And my worry about Hep C is we're going to declare elimination and then just, and move on. But you've got, what's the point of curing someone with Hep C if you're not going to do anything about their chronic, leg ulcers and their untreated hypertension? So it's about getting that sorted. There's great money in Hep C, and I'm starting to hear some things about, some sort of legacy and about how it integrates. Because if it's cost-effective intervention just on one disease, if you put something else on the top of that, that's fantastic. So I think we just need to keep bashing at commissioners, and they get it, but it's just where the money is, isn't it?
Okay, thank you, Julian. So the next question came from Ewan Stewart. Actually, this question I asked myself on Tuesday to the ODN leads. It's about providing a liver assessment prior to starting someone on treatment. So do FibroScan and then start someone on treatment. And Ewan specifically asked, and I presume to Julian, would you start someone without having done the liver assessment through FibroScan?
Personally, I probably would, but I think to get this same-day treatment diagnosis thing off the ground, it went through a lot of hoops. There's a lot of pharmacy considerations, and I'm sure many people have had the similar thing. The pharmacists did work very hard to get it up and running. So I think as a simplicity state, the patients, the majority, they're diagnosed by peers who've got good training. So just have some sort of, these are the simple, easier patients. They've not got any concomitant meds. They're not cirrhotic, therefore it's good to go if they're not cirrhotic. And I think just that simplicity. I think, a bigger question would be, yes, should we start people anyway? I personally would, but I think for this intervention, as it is just a rapid, really grassroots, peer-led, let's start someone on treatment, I think that was a fair enough sort of division. We like to do FibroScans anyway. I know, do we need to do FibroScans generally anyway? But we use that as well for liver assessments for people that have got a lot of alcohol use as well. So I think from that, we find FibroScan very useful from that point of view also. Yeah,
I mean, I think the upshot from Tuesday's discussion as well was to try for FibroScan as best you can. And I think there's conflicting evidence that's come out over the last 6 months to a year about the necessity of FibroScans or the validity of the result. After treatment, before treatment, and I think everyone's still shaking that around a bit and agrees that best practice is to get it if you can. And there's a lot of other benefits, obviously, of a liver assessment, obviously. So the next question is from Coldip, who's asked what proportion of patients have already been tested and diagnosed. I'm presuming I'm going to direct that one to Tracey and put her on the spot because I just wonder, is there any early data with, if I direct that now towards the self-test, for example, is there any data to show how many people have done the self-tests out of how many have been sent out and
so that kind of that's the stage that we're at now in terms of digging deeper, because ordinarily, if you were to complete a dry blood spot test in service, you can pretty much guarantee the time from a worker sending that test off to it landing at the lab, them doing what they need to do and the results coming back. It's pretty timely. Whereas what we did have to, there's a bit of a lag, I suppose, in that people who we send tests out, we know aren't necessarily going to think, oh, the test is here, I need to do that right now. So there's been a natural lag in tests landing at the lab, which is why when I was talking, one of our main focus right now is the back end of that process. It's so important to ensure that you're ringing up and speaking to people and encouraging them to do that test. But what we have seen is there was something like, I think in September, I think it was 457 self-tests posted out. And whilst we don't yet have the data fully of how many of those have come back, initially we had, I think it was something like 75 tests from one particular area that had landed straight at the lab, which we were really, it was in the northeast. So we're finding that clusters of areas and people are more engaged, maybe would you say? But we're digging deep now into the data to see what that looks like.
Okay, thank you, Tracey. I mean, I, for one, am very much looking forward to the data on the self-testing that's been sent out. And I had heard that same number, the 75, anecdotally through the grapevine, and I thought that was a fantastic start, actually,
Yeah.
that people are actually responding and self-testing and sending away their sample to the labs.
Something to be proud of. Someone's really
Yeah.
open to that, you know, yeah.
So the next question, sorry, Julian, would you like to come in?
No, I was just going to say, it'd be interesting to see, especially that a lot of the awareness stuff is done by different organisations, whether you could link out maybe in an awareness push, send out a load of tests on the back of that and see if that has an effect. But, you know, because it's obviously something happened with that 70, this 75 thing is going to grow and grow. It's going to become a fact, but obviously something happened there. And I think that's a great response. So, I don't know. I'd be really interested, likewise, to see the.
Especially when it was the start, isn't it? And we know things take. It's a new concept. Whilst we know about dry blood spot testing, the self-test is a new concept, and it takes time to bed in. And I think we need to be realistic about that.
Because we wanted to do that on the back of positives, give some, incentivize it somehow as well. Right, you're positive, you engaged on treatment. Here's a handle. You know, here's 5 self-test kits for your mates. And I don't know, you can incentivize it really, and then you're giving it to the ones that have got some risk as well potentially. So if someone's especially current injectors, even if they test negative, here's 5, you get 5 of each one that come back. I know you could probably, well, you could work out how people could play the system, but I don't really care. You know, I think that'd be, you know, there's some interesting stuff with self-testing. Absolutely.
It's a really good point. And how do you disseminate tests? It's a really good point, Julian. Can people hand them to the people they're using with, living with? And yeah, so it's fantastic. So there's a few more questions. I'm going to run a little bit into our breakout time, but I think that's okay. And then we can just knock 5 minutes off the breakout time. The next question is from someone called Tracey, but from the very nature of the question, I'm sure it's not Tracey Kemp who's asked it. So how confident are you that DBS kits or potentially infected equipment is being safely disposed of?
So this element of the process delayed the launch of testing, because I cannot tell you how many different conversations, different meetings we had to have to ensure that risk was mitigated where we could. And the thing that held us back was the Lancet. You know, what happens with that Lancet, and the amount of demos that we've done over Zoom, and we liaised with sexual health services who have done Postal testing for some time, and they've never, you know, they don't record any significant incidents. So it was about just really understanding what is the risk. How can we safeguard people? And we identified the main risk being the Lancet. Went to the governance team with PHE Manchester Labs to look at what would their guidance be, and made sure that we had a real tight mitigation around how do we keep people and others safe. And actually, the end result was that can go into general waste because the Lancet retracts on itself, and it's about that education, I suppose, when you are talking to an individual about doing that test. And this is why I talk about the appropriateness of somebody, you know, being offered a self-test. You know, where do they live? What are the circumstances? So it's about kind of viewing the bigger picture to help you mitigate risk.
Okay, thank you. So I think we'll just push on with 3 or 4 more questions, and we'll move to breakout groups. But my next question is my favourite one. It's from Delith in Wales. Hi, Delith. And she just simply says, "Hi, Tracey, do you cover Wales?" And I don't know if you want to answer whether you have CGL services. I think the fact that you've made the toolkit available to everyone is great, but would you like to answer to that, Tracey?
Yes, so as far as I'm aware, in Wales, we deliver like educational services, so employment services, not prescribing services as such. As you've just mentioned, Stuart, the toolkit is available. If it can be used in other areas, then use it to your advantage, I suppose, is what I'd say.
Okay, thank you. And then from Paul, how are the results delivered?
So the self-test results, so that's agreed at the point of testing in the same way that we would pre-COVID with DBST in service. So we would, you know, is it a phone call? Are we going to invite you back in? We agree that with the individual, whilst being very mindful, again, of the wider circumstances around this person. Are they likely to come back in for a result? Do you know where they are? Is it something that we engage with outreach teams to kind of go and find a person? But I suppose it's individual to how that person wants to receive their results.
Okay, and that leads actually, sorry to keep you on the spot, Tracy, but it leads into John Fox has asked about delivering harm reduction advice alongside the offer of a test. And I presume is that part of in the toolkit as well?
But harm reduction advice, it's all about bread and butter, isn't it? It's the stuff that goes alongside everything that we do. So the conversations around keeping yourself and others safe, you know, that just comes hand in hand with the conversation around the appropriateness of a self-test. So absolutely, it's what we do.
Someone else has asked if your test results are uploaded to the testing registry.
I'm not too sure about that. I can find out though.
That's a good question, because you are using Manchester Labs, aren't you? I think. Yeah. And they might be uploading. I don't know. I wouldn't. But it's a good question from Nigel. So maybe Nigel, if you want to come back, we can dig into that a little bit more. Petra again wants to know how quickly people are engaged into the treatment pathway, and presumably you've got a robust process to do that for any positives that are found.
Mm-hmm. I suppose, as everybody else, we've had to adapt processes. Things have been kind of shaven down to make access to treatment, I suppose, easier given the world that we're in. So it will differ region to region depending on what that treatment pathway is locally. But I suppose the key is in the communication around that result, and that's why it's so important to make sure that there's a clear plan around, once this result comes back to us from the lab, how do we communicate that to you and then engage you into treatment. But we are seeing more and more. It's variable dependent again on local restrictions, but setups of on-site HCV clinics, which for us pre-COVID were key in engagement. Obviously they drifted off, but it's positive to see that they're starting to be re-established.
Okay, well, thank you very much, Tracy. I know you was a bit on the spot there. The final thing from Delith is she's left her email for you, if you could get in touch with her. So it is time now to break out into the groups. You will all receive a little invite on the screen in a moment, and if you click that, you will then join your breakout groups, and we will see you back in about 25 minutes. Okay, hi everyone. I hope everybody's made it back to join us for the summary. We had a very interesting discussion in our group, but I'm now just going to ask the hosts of the individual breakout sessions just to give a 1 or 2 minute summary of discussion, anything interesting that might have come up when we unmuted everybody. So if I start with Archie in the top right. Hi, Archie.
Hello, hi. Thanks to the speakers. We had a very lively debate. We had a couple of technical issues, but they were overcome with the chat box. And we spent a lot of our time on the advantage, really. And I think the overriding thing from all three interventions really is more choice, more access. These are all positive things. So every service and every type of delivery in from the service-based, mobile and postal, they had their own different advantages. So the postal one, some of the new things that come up was things like anonymity, people not wanting to access visual services, and that there's a certain level of extra layer of confidentiality that can be acquired through the postal system. And just the fact that it's a new medium, new choice, more access now. So that was the main thing of that. How would you like me to do this? Do you want me to just settle on one, or just give you a quick run through of it all?
Just a brief overview of the discussion, some of the interesting points that came up. Yeah.
So that was one of the more novel ones. Issues with we would like to see a wider top-down approach to care as a whole, an integrated approach. I did mention something about the idea of that health passport, because governance can get in the way from joined up working a lot of the time, and so that was that thing. But generally, any of the problems, as Dee said, we can just get on with it. Is like we do get bogged down with bureaucracy and that, but we can find creative ways to work. And at the end of the day, we're all looking to eliminate Hep C, and that people don't necessarily need to live with this condition. We've got simple cures for it now, and we've been finding some great opportunities to get creative and find new ways of working. But it is there's that PHE thing, isn't it? It's everyone's responsibility. It's a public health concern. So we can find ways as a community to address it. And generally, we just like the things that people are finding. We're not getting rigid and stuck, and we're looking to find solutions anytime there's a new problem arises. Nobody was expecting COVID last year, were they? I think we've responded beautifully to it with new and novel interventions to meet it. And I think as long as we've got that approach, that we'll be in a good place. I think that was the general picture of it. I have got it all written down. I can pass on to the HTV action to have it typed up as summary, and that make that accessible to everyone.
Thank you very much, Archie. Thank you. So, Helen, how did you get on in your group?
Thanks, Stuart. I had a lovely group, and as I'm sure the other facilitators did as well. One of the highlights was how COVID has brought us all together and how we're all working together. And actually, we're only going to achieve elimination if we do all work together. So that was the real highlight, the real smiley point of it all. Having the option of different testing. So some, as we've already said, it's sometimes the service testing or the outreach or the postal. We're all different. All of our service users are different, and one model doesn't fit everybody. So it's lovely that we can have that menu of models, so we can look to see what best fits. We talked about our links with the Hep C Trust and the peers, and how well they do, and with the local authorities and coming out into the homeless. And that's the other advantage of COVID. We love, and I genuinely love the fact of the mobile clinic, and I want to be on that mobile clinic. Masses and learning about that it's not, even though we're here for Hep C, it's not just Hep C, is it? It's the other health within the homeless. So, and then we were just talking about treatment, that one of the services was saying actually it's not the testing, it's actually getting people into treatment, and how we might get people into treatment quicker. And that's when we did say about taking the treatment to the person rather than the person trying to find the treatment. So I think I've covered everything. So all in all, it was really good. Thank you.
Thank you, Helen. Tracey, how did you get on in your group?
All good, all good. Similar themes to what Archie and Helen have fed back. Some of the conversation we had around service-based testing was that human contact, and how that is a real advantage in terms of you can slot things in, can't you, like little conversation starters quite subtly that then open up a raft of conversation about potentially other health concerns or what's going on in people's lives, versus sending out a self-test. Do we lose some of that? So we talked about the self-test as there's a time and a place for it, in that it was developed as a tool, as a testing option, to support us in the world that we're in now. So whilst it is effective in doing that, there was just some query around, you know, what does that limit us in some ways? So I talked about how the process of checking and ensuring that, you know, people feel supported is key, to which Danny brought up an amazing point, which I'm taking away. How, so in the process of self-testing, we've got very clear points where we stop and we instigate communication, and we wrap our arms around people and say, we're here to support you through the testing process at home. Is that the point where what we should be doing is doing all of that, but also saying, and he's a peer, we're going to introduce you to.
Yes.
So that is something we're going to take away and amend the process, because it was kind of one of those light bulb moments of like, yes, Danny, of course we need to do that. So
how was that not in the original design, Tracy? How did that slip through?
What I said in our defence, the process of linkage to peer support is there in the outreach push, in service, and actually it hasn't been considered in a self-test option, and it needs to be there.
Yeah.
So that was really positive. We talked about, someone mentioned the mobile outreach and how one of the advantages that is the collaboration that comes from that. So you often get on your mobile van, there'll be someone from the trust, you've got someone from your drug treatment service, you've got your specialist nurses, all working together to formulate a process and an end point for somebody. And there's something like really powerful about that. So we thought that was a real advantage. And then, yeah, it was just, we talked about linkage to care and peer support, and there being a time and a place for the self-test option. And I think it was Helen's group who talked about, you know, that having a menu of testing options is appropriate and the way forward. And actually, we should all be building upon that together. So yeah, really healthy discussion.
Okay, thank you, Tracy. So that just leaves me to feedback. We did have a lovely group too, Helen, actually, in our group, and I'm sure you're all lovely. So first of all, we had the lead clinician for one of the networks in Scotland. So that was interesting because there's differences in the care system between England and Scotland. He was very excited to enable to access your toolkit. So I think a big thank you again, really, Tracy, for putting that toolkit out in the public domain. We had a fair bit of discussion about the postal testing. There was concern of the data and how do we feed that to the ODN and the clinics for them to understand actually how many people are getting tested. DNAs were mentioned by Diane from Leeds, and essentially, I think for us, postal testing, it's another arrow in the quiver, isn't it, really? And you've got to be tooled up now, because the road is getting tougher towards elimination. It would have got tougher anyway without COVID, because you work through the easier to find patients first, possibly, and the road gets narrower. So having more tools at our disposal is fantastic. But one of the things, I suppose, England's launched the pharmacy testing, which is similar in some respects. It's not quite a self-test, but it's like a remote test site. And what we've learned is that there's a real danger that you find positives through that intervention, but only 20% of them are seen in clinic for treatment. And how do you turn that around? And I suppose it's Danny who brought that up with you, Tracy, is when we went as a real whole team on the intervention in Birmingham, we turned it from 20% seen in clinic to 80% seen in clinic. And, you know, I think that it has to be a whole team approach. The clinicians, throw the peers in, throw the services who are doing the initial intervention with testing. And if you wrap that all around, like Archie said, the integrated approach, you've got the best chance for a successful outcome. We discussed the vans. Diane brought them up, so I think everyone's very excited to see our vans that are going to be going out. Scotland have a similar approach with mobile cephalids possibly coming online soon. And we discussed whole service testing. so blitzing services. And I think that's a model that definitely Helen and Tracey are aware of, and we've started doing a bit like the high intensity test and treat in prisons, where they can, you know, walk the wings for 3 days and test everyone in the prison. And you can do that in a drug service if you just wrap the whole thing around it. Everyone comes together and you decide to blitz it. I know, Helen, you've had some fantastic results with We Are With You. Possibly not that much easy to do in light of COVID, but I think what's come out of today for us is just the amount of, like Archie said, the amount of innovation and thought that's gone in. Okay, we're not going to let COVID stop us. We've still got to get on with the job at hand. And I'm really looking forward to the data. And I've turned from a skeptic to a believer. I believe the data is going to be good. And I think that it's wonderful to see CGL have had faith in their clients and said, you know what, you can bleed yourself, you can do this, and you know, we'll wrap the support around you and you can send a sample off. Okay, so that was our group. So it really leaves me to close the session 1 minute late, so I'm pleased about that. HCV Action have just posted in the chat that they will be sending out the sort of a script of today's meeting for everyone who's joined, but you can also access all of the webinars through their website, obviously. And it just leaves me to thank everyone for attending, obviously, but particularly for Helen and Tracey and Julian and Archie to help, who have participated today. So thank you all. Happy Thursday, what's left of it. And see you all soon, hopefully.